Now, our next speaker is Associate Professor Rachael McLean. Thank you, I forget to do that. She's a public health physician based in the Department of Preventive and Social Medicine here. And she did her PhD at the EDGAR Diabetes and Obesity Research Centre. I'm not sure when that was, but is Rachael here? Oh, she's here, sorry. So her research interests include monitoring population dietary sodium intake, public health approaches to dietary sodium reduction, and the relationship between dietary sodium and cardiovascular disease. Thank you, Rachael.
Thanks, Barbara. Tēnā koutou katoa, no otipoti aho ko Rachael McLean tōku ingoa. It's a great pleasure to be here today, and I'm to try and work this. No, oh, it does work, sorry. Should have practiced. So I'm going to be talking about dietary salt reduction, which is a very important thing that we should be doing. And my title is A Clear Path Forward Obscured by Fog, which is a reflection of some of what Louise was talking about earlier. So there's consistent and very strong evidence that limiting salt intake has many benefits on blood pressure and cardiovascular disease for both individuals and populations. We also know that most populations consume substantially more salt than is recommended by WHO, which is less than 5 grams a day for adults and less than that for children. And that's certainly the case in Aotearoa. And reducing population salt intake is a priority globally and has been identified by WHO as one of the 9 key interventions or voluntary global targets for reducing non-communicable diseases into the future. And they've recommended a 30% reduction in population salt intake by 2025, which is looming, and we are not going to achieve that. We know what to do. There is a raft of international evidence from local intervention programs and also from country-level intervention programs on what works, and a number of countries have managed to achieve this, including Finland, the United Kingdom and Japan. And WHO has put this evidence together and provided very clear guidance on what we should be doing, and they've put that together in their SHAKE action plan, where they highlight a number of interventions. And I'm going to talk a little bit about monitoring of population sodium intake or salt intake, the importance of reformulating the foods that we purchase and consume so that they contain less salt, and also implementing clear food labelling so that people can identify the sorts of foods that are healthy or the sorts of foods that have less salt in them. We also have a very strong evidence base in Aotearoa, and I've done some of this work and with my colleagues both in the EDGAR Diabetes Research Centre and in the Department of Human Nutrition and also in the University of Auckland. But we know that salt intake in New Zealand is substantially above recommended levels. Adults consume on average about 8.5 grams of salt a day, and some recent work I've done with Helen Isles up in Auckland shows that children also consume more than is recommended. Helen has done some work and produced a New Zealand salt reduction model, which is, I've got over there. I know you can't see it, but it's very clear what we need to do in order to achieve the WHO target. Some recent work that we have done for MPI has shown that discretionary salt, so that's the salt that we add ourselves in cooking or at the table, is only around 13% of our total intake. So we have very limited control over the amount of salt that we consume. And we know that the current reformulation strategy, which sits in the Heart Foundation, and it's called HeartSafe, it's an industry-led strategy, and it will not meet the WHO target. Even if it's implemented at its most optimal level, it will only achieve about an 8% reduction in population salt intake. So we're not doing enough in Aotearoa, and recently the WHO rated countries on their public health interventions to reduce salt, and they only gave us a 2 out of 4, so you can see we're amber. And many countries get a green or a 3 or even a 4 out of 4 from WHO. So we are really lagging behind. I'm going to skip that. So we know what to do. Why aren't we doing it? And the reasons why we're not doing it is what I've described as the fog. And so I'm going to be talking about a couple of those. The first one is controversy and debate around some of the evidence. So I'm glad I've followed both Jill and Louise in this session. So we know from evidence from randomised controlled trials that there is a clear effect of salt reduction on blood pressure lowering. It's more difficult to do randomised controlled trials over many years, but some have followed people up for longer than several months and over up to 20 years in one particular trial. And there is strong evidence that reducing salt intake also reduces your risk of cardiovascular disease. It's much easier to do observational studies or cohort studies where you take a group of people and you measure how much salt they eat and then follow them up. But there are a number of problems with cohort studies. Confounding is one, but measurement is the one that I am particularly interested in. And measurement of usual sodium intake or salt intake is very important in cohort studies, but it can be quite difficult, and a number of groups don't do it very well. And that's because the best measure is several 24-hour urine collections, sort of between 3 and 7. And if any of you have done 24-hour urine collections, it's quite onerous and lots of people don't like doing them. 24-hour dietary recall can be useful, but a single spot urine is the most easy and convenient, but the work that I've done and many of my colleagues have done have shown that it's a completely invalid measure of usual salt intake. However, some people have done this because it's easy and cheap, and they have published their evidence, unfortunately, in very high impact journals such as The Lancet, and this is a couple of the examples of these studies that are completely inadequate and invalid because the measurement of sodium intake at baseline was used using a single spot urine. Why were they published in the Lancet? I suggest that's because they're medical journals, not nutrition journals, and the peer reviewers are not nutrition people, they're medical people who don't necessarily have a wide breadth of knowledge in nutrition. These articles do say that this is a validated method. What that means is we did a validation study. It doesn't mean that the validation study showed that it is a valid measure. It just means there's a study and I can reference it. And controversy is very sexy in medicine, and it gets in the paper and it creates a lot of scientific debate, and people show their papers in their seminars and they refer to them and they cite them in their papers. But having done these studies, the authors have stuck to their guns, and it has created quite a lot of scientific debate. It's got quite heated at times, so here's one of their commentaries about accusing some people of zealotry for supporting dietary salt reduction. And the final comment here is that measuring sodium intake in populations, simple is best. This is a spot urine. This is about 3 mils of urine, and it really is completely ridiculous to think that a single spot urine that reflects your salt intake over the last hour or two would approximate your usual salt intake. And I've done a lot of research in this area with a number of colleagues. Here's a paper on the left here from my PhD that with Sheila and Jim, looking at using spot urine samples that showed that it was a poor predictor of 24-hour urinary sodium excretion for individuals. And I've also contributed to a number of systematic reviews in this area as well. And of course, we've quite enjoyed scientific debate, and with a number of my colleagues, we've published commentaries, we've written letters to the editor, we've called the research flawed. It's been quite fun, but the downside of that is it has led to many countries delaying implementing effective population salt reduction strategies, including New Zealand and the Ministry of Health, who have not supported dietary salt reduction strategies, partly because the evidence is possibly unclear. But actually the unclear evidence is of very poor quality. And we've seen this before, this sort of creation of scientific controversy and stirring up the pot in terms of, but is it real, is there any support for that? The evidence is a bit controversial, the evidence is unclear, and the tobacco industry has used this very effectively for many, many years, and the food industry is using it as well in a number of areas relating to food research. So confusion and controversy over the evidence is one of the reasons that we haven't implemented reduction strategies. One of the other reasons is, I just see I've got a obviously deliberate typo on that slide. One of the other reasons is the direct influence of the food industry on government. And we've seen it before and we're likely to see it again, particularly in the next few years. So in New Zealand, evidence supports the use of traffic light labelling. We've ended up with the health star rating, which, although not ideal, is the one that we've got. Salt intake is a component of the health star rating, but there's been very poor uptake of the health star rating. 36% of products in Australia in 2023 and only 5.3 in Aotearoa in 2016. And we do have a trans-Tasman system of food labelling, and so we need to work with our Australian colleagues in this space. During the election campaign, Shane Reti, who's now our health minister, said that he wasn't supporting the health star rating system. He thought we might be able to come up with something a bit more effective, but actually I think he's signalling that he has no appetite for making it compulsory on products, and he's not going to support the rollout of the health star rating, even though there is increasing evidence that it helps people choose healthy products. Finally, is there consumer resistance? Do people really care? I ponder this a lot in my advocacy for salt reduction strategies. Are we too focused on sugar? Are we more focused on ultra-processed foods? And this is another study conducted by colleagues in Australia that show that there is public support for salt reduction strategies, for manufacturers to reformulate their products and to have simple labelling to help consumers identify high salt products. And Louise has just demonstrated quite nicely another study that conducted more recently in Aotearoa that demonstrates the same thing. So thank you very much. I'm going to finish there because I'm a bit of a nerd. I've got references if anyone's interested.
That's really good. Thank you, Rachel. Just one kind of naive question. What about a salt index, a bit like a glycemic index that you put on food labelling? Is that possible? You know, a like number to me would mean more than the red probably of the, I don't know.
I mean, there's a number of different ways you can do it. In Chile, they have warning labels. If you can see those down on the bottom right, and a number of countries in South America have introduced warning labels on high salt products. I guess the health star rating is a bit like a 0 to 5 index, isn't it? Yeah, there's a number of ways you can do it. The simpler, the better.
Okay, anybody got one question, please? Mike.
At the risk of elevating your blood pressure, Rachel, this debate about the single spot urine, your paper has shown, as others have, that a single spot urine is no use at all to identify these 24-hour, to correlate with 24-hour excretion in an individual. But much of the work is being done in groups and in quite large studies where you're looking at shifts, quite small shifts at a population level. I mean, I showed data on liver fat measured by magnetic resonance spectroscopy. We showed nice data, and that's been quite well accepted. It's completely impossible to do it at an individual level. So the association between liver fat measured by some obscure dissection and what you get from magnetic resonance spectroscopy cannot be used at an individual level. But when you do a group, then you do get a clear message. And I just wonder if we haven't made too much of this debate. It depends what the research question is.
Yeah, I mean, ecological studies have also shown that high salt populations have much higher blood pressure and cardiovascular disease, and the very few low salt populations that there are don't even get an important rise in blood pressure with age. So if we're looking at groups of people, then it shows the same thing. It's just when you use an individual spot urine in an individual and compare it with their individual outcomes of cardiovascular disease, as you do in a cohort study, that's where it doesn't work.